we moved very quickly from one point to the next. So Gigi already started her own introduction. So I'm Misha Kogan. I'm also one of the faculty here at GW. Before I introduce Dr. El-Bayoumi, I just want to mention something. So one of our updates is that's related to what Tracy and Wayne was talking about is, so we're quite in the middle of the COVID and now post-COVID. And I think we're attempting to figure out how we're going to bring some of the whole health and integrative modality to our post-COVID patients. So stay tuned. We're trying to get some grants, and I started seeing patients with post-COVID clinic. So it's going to be a kind of a new direction. I think we're going to see a lot of really long-term significant complications and be all dealing with this. But anyway, well, it's a tremendous pleasure for me to introduce our next speaker. I can definitely say that Gigi has not only been a flagship of kind of a heart of medicine at GW, but also my own personal mentor and later colleague. And I also just realized, noticed that 3 faculty on this symposium, Dr. Penn, Dean Bass, and Dr. El-Bayoumi, have all been trained here. In case of John and Gigi, their entire career has been on, and now Dean Bass has come back. So I think it's telling, and I'm quite honored that I'm around here too. So with this, so Dr. Jehan El-Bayoumi, she goes as Gigi, is the founding director of the Rodham Institute at the GW School of Medicine and Health Sciences. She's a full professor of medicine and a board certified internist. She has very busy clinical practice. I know that for sure, because I do see some of the patients that she refers to me. In 2013, in the honor of the late Miss Dorothy Rodham, Dr. El-Bayoumi established Rodham Institute that has since been applying a transformative power of education to achieve health equity in greater DC area. Rodham Institute strives to increase the number of underrepresented minorities and healthcare professionals, to partner with and support initiatives, programs, and objectives of community-based organizations that will improve health outcome for underserved population and educate current and future healthcare professionals in applied health equity with a focus of social determinants of health. Gigi received her undergraduate degree from Ann Arbor, and then she moved to DC, and she completed her internship residency, and then she served as a chief resident here at GW and stayed on faculty after. She was clerkship director for a number of years, and then for 15 years, she was the director of the internal medicine residency. So she trained numerous residents. Her clinical interests are women's health, minority health, and smoking cessation. In 2014, she received a certificate of appreciation from the White House for providing expert care to members of the White House staff. She sees a variety of different, not just the White House member, but all kinds of VIPs. She is very active in School of in Milken Institute for Public Health. She's teaching on a variety of topics. And in 2020, just recently, she has received one of the most distinguished service awards from our own university as a SM, School of Medicine and Health Sciences Distinguished Service Award, which is given to faculty who has demonstrated exceptional service and citizenship to the GW School of Medicine. And especially, I just want to highlight that every time a patient gets referred to me from Gigi, they say that they feel like royalty in her presence, no matter whether they have, a Medicaid or any other insurance. And I think this really tells who Gigi is, how big her heart is. And I think I'm proud of calling her my role model and my mentor. And I'm sure a lot of physicians at GW, as well as trainees, can do the same. And it's a tremendous pleasure to have Gigi start her talk, which is called Future of Medicine for All, which I think is perfect fit for this year's Symposium, because of course, the whole health has to be delivered to everybody, not just to those who can afford cash prices of it. Welcome, Gigi.
Well, thank you so much for that warm introduction. I really appreciate it. And, before, while we were planning this, I said, please don't do a long introduction. And then, of course, patients started to call and everything. I'm so glad that you did a long introduction because that gave me time to put up my PowerPoint. So thank you for that. And thank you, Misha, for your leadership and your work because, I hope that everybody knows that Misha actually published the first book on integrative medicine in the geriatric population. He brought together his geriatric training with his love and interest and dedication for alternative and integrative medicine. So that is a Bible that I use, and certainly I've learned a lot from him. So what I'm going to do is I'm going to try to do this. I'm going to share my screen to allow, you know what I'm going to do? I'm going to do this. I'm going to cheat a little bit. I'm going to send this to you, Ms. Rodriguez, and I'm sure that you're listening because I don't know how to do this so well. I'm just going to forward it to you. But while I'm forwarding it to you, let me tell you, we have been very busy at the Rodham Institute. But before I go into the Rodham Institute and the work and health equity for all, I just want to sort of share my personal story for you so that you can understand sort of the context that I'm coming from. So I was born in the United States in Florida, grew up in Michigan, and the daughter of two professors who are also activists. And I'm of Egyptian heritage. So in the summertime, we would go to Egypt, spend some time there, probably about every other summer. And so I feel very lucky that I had the exposure of both sort of Western culture, but also Egyptian, very, very old culture. My grandmother, who is my father's mother, was sort of one of the brightest people that I ever met. She was not, formally educated beyond, sort of the usual school. She didn't go to college, but she was a healer. And what was great about her as a healer is that she knew when to kind of use sort of the traditional treatments versus, sending somebody to the hospital. And so I'm going to share a story with you that really made an impact on me. I think I was about 14 years old. So my sister and I went, just the two of us, to spend time with my grandmother. My sister was 11, I was 14, and my sister got sick with hepatitis A. And, she was also very homesick for my parents. My parents stayed in Michigan. It was just the two of us. We were there for about a month. And so as any child, you kind of want the comfort of your own parents, especially your mother. So my grandmother said, I know what I'm going to do. I'm going to do a special treatment for you, she said. She came back with a newspaper and she cut out a paper doll. And that paper doll, she put like kind of a wire at the top. And she started to ask my sister, who are all the people that you have seen today since you've gotten sick? So my sister mentioned all the names, and with each name, my grandmother would puncture a hole in the paper doll. And she said, are you sure you don't have any other names to add? I said, no, I don't have any other names to add. She goes, oh, wait a second. What about the cats? Yes, add the cats. And then what my grandmother did is that she burned this paper doll and she walked around my sister's bed 7 times, and my sister fell asleep. And we left the room and I said, Gedito, do you believe in that stuff? And she said, it doesn't matter what I believe. It's what she believes. She's sleeping, isn't she? And so she had that sort of that healer's touch. But at the same time, when my first cousin, who was, I think, a year old, developed sudden abdominal pain, and my aunt wanted to take him to the hospital, and her husband wanted to go to a wedding, she said that he said, no, we have to go to the wedding. My grandmother said, take him immediately to the hospital. And sure enough, he had volvulus and needed immediate surgery. So I feel lucky that I have sort of those traditions and can borrow sort of from both and understand both the benefits, but also the limitations of each system. So that's a bit about my background. And as Misha sort of mentioned, I am a general internist. I take care of a lot of patients, mostly outpatient, but sometimes in the inpatient setting, less so now. Although I was working in May for a week taking care of COVID patients in the hospital, and also a medical educator. And I want to tell you that we have problems in our healthcare system. And I think that COVID has helped to expose these problems for just ordinary people, ordinary Americans that may not have been aware until COVID happened. But I think that these problems have really existed for a very long time. So first slide is, what does health equity look like for all Americans? Next slide, please. Thank you. Disclosures, none. I'm an academic general internist. And as Misha mentioned at the top, I established this institute 8 years ago now in memory of Mrs. Dorothy Rodham. For those of you that don't know Mrs. Rodham, other than she's the late mother of Secretary Hillary Clinton, she was a remarkable woman. And I would really tell you and suggest rather to read a little bit about her. And everything I'm going to tell you is a matter of public record. I'm not saying anything private. She actually came from a very, very modest means, very modest means. She was actually deserted by her parents, and they shipped her off on a train when she was 7 and her sister was 5 from Chicago to San Diego by themselves. Imagine that. To her grandparents, who were really horribly abusive of her. And she became, quote, emancipated at the age of 14. And really it was because of the kindness of strangers. And they took her in and said, look, if you clean the house and basically get our kids ready for school and help them with their homework, we'll let you finish high school. And she did. She was also one of the smartest women that I ever met, but did not have the chance to get a formal education, unfortunately. But she poured all of her love and her intellectual curiosity and her love of reading into her daughter and to her granddaughter. And so I thought, what better person to choose to honor them through the Rodham Institute. Her love of education was very important. And she as a person was very modest and very down to earth. She was my patient. She would come, she would sit in the waiting area. Nobody would know who she was. She would wait her turn, just a, Midwesterner, right? And I think we also clicked on that level. Next slide, please. I want to just share with you a picture of Washington, D.C. Washington, D.C. is like a diamond, I like to say. And you can see that it's got 2 rivers, one that is on the northwest side, which is the Potomac, and then a sort of a natural other river, which is the Anacostia River. It's a little bit obscured by the lines there as a natural division point between Southeast and the rest of DC. You see where GW is at, and I'll talk about Berry Farm in a minute. Next slide, please. This is really something that if you have not seen this, I would recommend, and I'm going to give you the reference in just a second. This is from Uneven Opportunities. This is now about 2.5 years old. Virginia Commonwealth University, funded by Kaiser Family Foundation, put this 76-page document, which you can access for free online. And what is dramatic is that now remember, Washington, D.C. has a 10-mile span. And if you live in Trinidad, which is one of the sections of D.C., you can live, on average, your life expectancy is 67 years. But if you live in Georgetown, your life expectancy is on average 94 years. I mean, that's 26 years across the city. across the capital of arguably the richest country in the world. And remember, averages don't tell the whole story. Next paragraph. Next slide, sorry. I just wanted you to see it's uneven opportunities, and it's an online study of DC, Maryland, and Virginia. Next slide, please. So when you're looking at averages, it doesn't really tell the truth, the whole truth. And sadly, DC leads the country. We're number one, not in a good way, per capita of cancer mortality, HIV, and end-stage kidney disease. And if you kind of look further, we've got 8 wards. Ward 8 has the same HIV rates as Namibia and the same rates of infant mortality as El Salvador and Cambodia. 84% of the COVID deaths in DC were among the African-American community. That puts us at number 7 per capita in African-American deaths in the United States. Next paragraph, please. Next, you can tell I dictate a lot, right? Ward 7 is also not a very rich ward, but it is a little bit more heterogeneous than Ward 8. Ward 8 is sort of uniformly poor. Ward 7 is a mix because a lot of retired government workers live there. There is more sort of, some of them own their homes. But for Ward 8 in particular, I would say you've got so many challenges. The healthy food options, there's actually only one full service giant that serves 79,000 people. Returning citizens, pharmacies that are not always open on the weekends or after hours, healthcare access, we'll come back to that. And then the emerging really structural and social determinant of health, which is gentrification. And I write Ward 9 up there, not because we have a Ward 9, we don't, but some people refer to Prince George's County, which is in Maryland, as Ward 9 because people are being displaced there from Ward 7 and 8. Next slide, please. So, we talk about the social determinants of health. I would add the word structural. That's actually from Dr. Arnaud, who is the head of health equity in the Department of Health. And really, if we think about the structural and social determinants of health, it's about the things that we cannot control. In the United States, the family that you're born into is a family that determines your health and life expectancy, which is very different than in other countries, especially in the industrialized world. For example, if you live and are born to a physician in Norway, that the possibility or probability that you're going to be a physician is not necessarily, doesn't necessarily correlate. Whereas here, that tightly correlates, and you're almost born into a caste system and you stay within that system. Although we love what we do as physicians and as clinicians, and we work in the healthcare system, really only about 20% of life expectancy is related to the healthcare system. Only 20%. Next slide, please. The other things include the water you drink, your educational level, the air that you breathe, the food that you eat. I will tell you this. I told you that there's a 26-year span between the very richest and the poorest in DC. Education is one of the strongest social determinants of health and correlates with life expectancy. Right now in Ward 8, 42% of kids graduate from high school. Imagine if all we did as healers, as doctors, as clinicians, as nurses, was to get kids to graduate from high school. We would add 10 years to their life expectancy, just to give you some idea. The thing about Washington, D.C. that's so interesting, and this is a little bit different than other urban areas where there was redlining, where there were, very clear divisions, such as in Chicago, which there's Division Street, between white and Black communities. Anacostia, which is within Washington, D.C., is a little bit different. It was initially going to be a port for a federal city, and of course, there was opposition from Alexandria and Potomac. And Barry Farm was in Anacostia. Now, people tend to think of Barry as meaning or referring to the late sort of mayor for life, Marion Barry, but it's not. Barry Farm used to be the Barry Farm tobacco plantation. Next slide, please. And the freedmen were given, this was after the Emancipation Proclamation, they were given 400 acres that they transformed into a thriving farming community. After they would till the fields, they actually walked, which is a long walk, at least 6 miles, to build Howard University. They built it. And at its heyday, 1 in 4 adults attended Howard University, whereas now 1 in 4 are in the prison system. So when people talk about, oh, Black folks don't eat fruits and vegetables and don't know how to eat and they need to be educated, well, actually, that's not true. If you talk to older people from Barry Farm, they will tell you they remember when they would just pick an apple from the tree. I mean, it's a farming community. So things have been transformed. And I like to refer to Washington, D.C. as a city with musical chairs. And every time a chair is taken away, the people who are always left out are Black people. Because actually, Georgetown has the oldest African-American church in the city. So people keep getting moved around. So Georgetown was an African-American community at one point, so was Capitol Hill, so is now Ward 8, but that's changing, and every time people get displaced. So I want to tell you about the Rodham Institute to give you some context, because it's not enough to talk about problems. I think it's just as important to talk about solutions. And I'd like to have some time to discuss these solutions with you. So the first thing that we decided is that we want the Rodham Institute to really be an action-oriented institute. Because if you think about health disparities, you can sum them up in one sentence. If you're poor, if you're Black, brown, or of color, if you're have mental health issues, if you're disabled, if you are a returning citizen, if you're undocumented, if you're homeless, if you're a senior, if you're LGBTQ, if you're deaf, if you're blind, your outcomes are worse. And also women, depending on what background. And if you think about it, all of us are eventually going to be in one of those groups, right? All of us. And so we wanted to really see what we can do and where we can really have the biggest impact. So we brought together 100 people from all over the city, from academics, interprofessional, and we asked the question, what should we focus on? And after 3 hours, we were told that education and food were 2 things that we needed to focus on. The education I understood, the food I had to come to understand. Food is actually the #1 social determinant of mental health. And this work comes from Dr. Michael Compton, who used to actually be in our psychiatry department, now is in the Department of Health in New York City. And he wrote an excellent book called The Social Determinants of Mental Health. It's an edited book I would recommend that you check out. And then Secretary Clinton gave us a charge and said, it would be great if you could develop a model where you don't reproduce the wheel, where you share resources, which is sustainable and really can be upscaled. Next slide, please. So our guiding principles are these, and I think that this is so important for any work that's being done about health equity, and really should be the guiding principles of our healthcare system in general, right? The communities in the driver's seat should be inclusive, it should be consistent and respectful for people's dignity and their autonomy. We should build a bidirectional bridge, and that the gestures reflect the principles, and that we're transparent, and that there is reciprocity. So in other words, next slide, please, that we're not just there, to pilot in, do a study, and then pilot out. No, we are clasping hands with the community to have them go from interdependent to independent, to have self-determination. So what I call the Rodham Institute is, I call us glue. We convene, we connect, and we catalyze. One thing about DC, academic medicine in general, and other sort of microcosms that we live and work in, we're really quite siloed. And maybe that's one of the silver linings that the pandemic has shown us, is that we can no longer afford to be siloed. And we've been playing a role of glue for many years now. Fortunately, glue doesn't get a lot of funding, but we'll talk about that another time. Next slide, please. So here were some of the participating organizations. You can tell I had less gray hair there. Next slide, please. And so really our vision is to produce a cadre of healthcare professionals to really help to advance health equity, and is to partner, our mission is to partner with local DC community to achieve health equity. Next slide, please. Is that me or you? Oh, that's you. Okay. Next slide, please. So these are sort of the three areas, and then I promise to stop the formal, slide part. We do community collaborations, workforce development, and educating people who are currently working in the healthcare system about applied health equity and the structural and social determinants of health. Next slide, please. We started our work by actually commissioning a community health worker to do an environmental scan, because we wanted to know what the health priorities are of residents of Ward 7 and 8. And actually, to my surprise, although now I understand why, mental health, not HIV, not cancer, not obesity, was their number one health priority, which has really informed our work. Next slide, please. So I want to stop here and talk a bit about our work during the time of COVID, because I believe that this will serve as a model. And maybe we can stop the slides now, and we can just talk and have a discussion. So COVID, I always say, is the latest example of the health disparities in our city and our society. I would argue that COVID really, and how it was handled, really sent a very sad message to members of under-resourced, underrepresented, or minoritized communities, and that is, you don't matter. So if you remember the past administration, when COVID deaths were happening, they said, well, if you're 70, you've had a good life. So basically, forget seniors. If you have, underlying conditions, well, you didn't really die of COVID. You died of diabetes, which makes about as much sense as somebody going in an airplane and the plane crashes and they say, no, they died of diabetes and not the plane crash. And then finally, certainly if you're Black and brown, since a third of deaths were happening, then you didn't matter. So really, if we think about our medical system, it is a system, especially now with COVID, that you need. It's not only about being educated, it's also about having the wherewithal and sometimes the resources to navigate the system. So I'll give you an example. One of my patients is a billionaireess. So when the vaccine came out, she actually chartered a plane down to Florida, got her vaccine, came back, and 3 weeks later, chartered a plane back down to get her vaccine. So yeah, some people have access and others do not. But I think what happened with COVID is then you began to see how all of these other social and structural determinants of health really began to impact health, right? Poverty and education and all that. But not just that COVID actually increased the divisions. So let's take an example, the digital health divide. Well, so when we were adapting to COVID in the healthcare system, we said telehealth. It's like, okay, great, people can have access. And, it was more convenient for some people, got rid of some of the transportation barriers. And patients love it. Clinicians, I'm not sure yet, because there are certain challenges there. But okay, that was a great, we adapted. Except for the people that don't have internet, that don't have computers, and even if they do, don't have computer literacy, right? And remember, 1 in 3 Washingtonians are functionally illiterate. That's just regular reading and writing. We're not even talking about computer literacy, right? Which we know is a whole other thing. And I can tell you, I can attest that at the beginning of the Zoom calls, I would see the top of somebody's head or maybe, the ceiling someplace. So that's for people who have the technology. So actually this divide is increasing. In education, which I just said was a key social determinant of health, the divide is increasing among Black and brown kids. And then you layer on top of that, Black and brown kids who are disabled, they're actually losing not 1 grade, but 2 grades. And that's another point I'd like to make. And that is we tend to, and I'm doing it to a large extent right now, kind of paint a minority or a group with one brush. And it's much more complex than that. I think we tend to forget about minorities within minorities. For example, disabled children in Ward 8 have triple and quadruple the challenges that disabled children who live where I live in Ward 3. Or undocumented folks who are disabled or who have mental health issues or are homebound, or I think you get the idea, is that we have to be careful when we're looking at these issues to try to get some really granular information, because that's going to be more meaningful as we think about the ways that we're going to have a solution. That's going to be really important. So I know I have a few more minutes left, and I'm just going to present to you what I believe is the way that we can solve some of these problems. My father, who's a retired physical chemistry professor, says, when you're dealing with a complicated problem, it's kind of like eating a hamburger sandwich or a vegan hamburger sandwich, plant-based. And that is, you don't eat the bread and then the tomato and then the lettuce. Somebody's unmuted. And maybe you can mute. I think that's, yeah, somebody's unmuted. I can't tell who. There we go. You don't eat the bread and then the lettuce and tomato and then squirt the ketchup and mustard in your mouth. No, you have to eat everything at the same time. And so it is with health equity, because it is about economic development. It is about education. It is about housing. It is about mental health. It is about the healthcare system as well, certainly. It is about food. It is about environmental issues. It is about social justice and justice in the courtrooms. It is all of these things, right? I think that health is sort of the canary in the cage. If you look at our numbers in the United States of America, we're not number 1, we're number 40 in terms of health outcomes in the world. That's pretty bad. And so it was predictable on some level that when a pandemic hit, that we would have an uncovering of all of these issues. But I believe that we have an opportunity to holistically, and by the way, economically, even though there's some initial investments of monies that have to be done in terms of infrastructure and a lot of these other things that we're seeing this administration put into, it's actually going to save money at the end. Because for being number 40 in health outcomes, we're number 1 in terms of expenditures. So I'm going to close by sharing our recent mass vaccination campaign, where we got 886 people vaccinated on one day in Ward 8. First of all, we were invited by the former mayor, or the late mayor, Marion Barry's widow, to come and do this vaccination event at the Southeast Tennyson Learning Center. Then what we said is, sure, we'd be happy to, but you know what? I had noticed a lot of mental health issues and food issues among my patients. Wouldn't it be great if we brought in those people from Food and Friends, Capital Area Food Bank, to be there? We also brought Whitman Walker, who did education about PrEP and PEP. We brought health literacy. But the thing that I'm most proud of is that we brought every single academic institution. we brought Children's and GW and Howard and Georgetown. We brought the community-based organizations were actually the ones that were leading the charge. They were the ones that were registering patients. They were the ones that had the 3 touch points with patients before, or residents, I should say, before they came for the vaccine. I'll be happy to talk a little bit more and give you a little bit more in the way of details, but this model is not a one and done. It is just the beginning of what we hope to continue. And it's not unique, but I just wanted to share that with you, because if we're going to be effective, we have to let the community-based organizations be the leaders. We did train the trainers so that they would know what information, we answered their questions about the vaccine, but that also helps increase the social capital of the community itself, right? And they became ambassadors for the vaccine. So I'm going to stop there. I can obviously talk for a very long time. I want to just thank you for the opportunity to speak, and I hope we have some time at the end for some discussions. Thank you.
Thank you so much, Gigi. That was so necessary to have in this conversation. And you did a really great job of highlighting all the components, the